Good afternoon. Welcome to the 7th webinar in our Advocates and Allies series. My name's Carmel Tebbit. I'm the CEO of the Mental Health Coordinating Council, and I will be your host today for our webinar, Realising Rights and the Voices of Older People with Lived Experience. I want to begin by acknowledging the traditional owners of the land that we're meeting on. For me, that is the Gadigal people of the Eora Nation, and I pay my respects to elders past, present and emerging. I also want to acknowledge the contribution of people with lived experience of mental health conditions to mental health reform in Australia. I'd now like to introduce our fellow speakers. I have with me, and they will turn their cameras on as I start to introduce, I have Robert Fitzgerald, who is the Ageing and Disability Commissioner. Welcome, Robert. Thanks for joining us. I have Liz Abbott, who is the Acting Director of the Older Persons Mental Health Policy Unit at the Ministry of Health. Hello, Liz. Welcome. I also have Bryan Hoolahan, who is the Senior Policy Officer from the Older Persons Mental Health Policy Unit. Hi, Bryan. Welcome. And I have Bharat Nepal, who is the Senior Peer Worker with the Pathways to Community Living program. Welcome, Bharat.
Thank you so much.
Great that you could all join us today. So we'll be hearing from our fellow speakers shortly, but I'd also like to thank everyone for attending this webinar today. This is the last in our Advocates and Allies series of webinars for this year, and it's great that we've ended on such a strong note. We've had over 150 people register for this webinar today. So that shows there's still a huge interest in this series of webinars. And these webinars are really aimed at mental health workers in the community managed sector, with providing information about how the broader mental health and human services system works and some best practice approaches that are relevant to the work of the community managed mental health sector. So as I said, today's webinar is about recognising the rights of older people with lived experience and how their voices are heard through the work of the Ageing and Disability Commission and also the Older Persons Mental Health Services in the Ministry. We're going to hear from our speakers first, and we're then going to move into a panel discussion, and I'd really like audience participation. So if you've got any questions that you'd like to put to our speakers, please put them in the chat function or the Q&A function. Probably the Q&A function works better, but I'll try and keep an eye on both. We're due to finish at 3:15 p.m, but if you are unable to stay for the whole event, it will be recorded and it will be on the MHCC website in a few days, so you'll be able to access that. So we'll now move into our presentation. So I'd ask all of the speakers other than Robert to go on mute and turn your cameras off. And I'll introduce Robert Fitzgerald, who, as I said, is the inaugural New South Wales Ageing and Disability Commissioner. We say this about many people, but I really do think Robert is one of those people who does need no introduction. The role of the Commission is to prevent and respond to the abuse of older people and adults with a disability, especially in the family and community settings. But of course, Robert has a long history working in the community services sector, a former Productivity Commissioner, a former Community and Disability Services Commissioner. He served on numerous boards, including as chair of the ACNC Advisory Board and president of the Australian Council of Social Services. And Robert's currently a board member of Social Ventures Australia and Caritas Australia. So thank you, Robert. We know how busy you are, and it's great that you could join us to speak about the work of the Commission. So I'll hand over to you. Thanks.
Well, Carmel, it's a great joy, and thank you very much for the invitation. And it's a real pleasure to be on this particular webinar. I want to just start by acknowledging the traditional owners of the land upon which my office is located, where I am, which is the Parramatta people. And they've had 60,000 years of association with the Parramatta River. But I want to do it in the context also of the Uluru Statement from the Heart, which is getting a lot of attention, because there's two things in that document which are really important. First is the invitation to you and I and the rest of the Australian population to accept the call for a voice to Parliament. The Uluru Statement from the Heart calls us to listen to what Indigenous people want, and not to respond as we would wish, but rather to respond as they have asked us to. And the second is a statement which is extraordinary, and it is the torment of the powerless. And it is in that statement that in many senses resonates the truth of what's happened in the past. That is, without power, without the recognition of the powerlessness that has existed, then all the services and supports we do will come to very little. But ironically, in the work that I do, that is around preventing and responding to the abuse of older people and people with disability in New South Wales, those two things are also important. If you talk to older people, the one thing they say is they become invisible. And we know that for many people with disability, for much of their life, they indeed were invisible as well. The second thing is, and the worst thing that can happen is when they lose voice. And people say to us that I've no longer got a voice, I've become voiceless. And so in many senses, my work and your work is about giving both voice and presence to older people and people with disability, particularly those that are at risk in our community. And the Commission, when it was started in 3.5 years ago, I think is about that. But it is rights-based. Our Commission, the first of its kind in Australia, is really based on a number of rights. But I just want to read to you just a couple of those because they are very important to how we see our work. And that is in relation to adults with disability and older people. They have the right to respect for the worth and dignity as individuals and to live free from abuse, neglect and exploitation. Surely that's a right that none of us in any way would quibble with. The right to live free from abuse, neglect and exploitation. There's other rights. The right to respect for their cultural and linguistic diversity, age, gender, sexual orientation, and religious beliefs. And in this space, those things truly matter. For many of the communities we do, many of the ethnic communities, the COL communities, are their beliefs, their particular orientations, their particular way of living is critical to understanding the nature of abuse in their communities. But then I think most importantly, adults with disability and older adults have the right to exercise choice and control in the pursuit of their goals, a notion that underpins the NDIS and will underpin the aged care reforms that are being rolled out, but also in the planning and delivery of their supports and services. And that is really a critical element. To what extent do agencies like myself really engage people with lived experience of mental health issues in this case, and those associated with psychosocial disabilities in particular? So just a bit of a snapshot about the Commission. The Commission takes about 13,000 calls a year through its helpline, a helpline that is genuinely a helpline. That is, it's not simply about intake. It starts to work with people who have concerns, who are raising questions, or to make formal statutory reports. And then those matters move into two areas if they're not resolved very early. That is either community support, which effectively tries to find the problems that have existed, the difficulties in the relationships, and the services and supports that might be necessary. And we have a third stream that is into investigations, where these are serious areas of misconduct and may in fact lead to people being held to account in various systems. Uniquely, this legislation is quite interesting. That is, every person over the age of 65, an Indigenous person over the age of 50 in New South Wales is in my jurisdiction. But what it does is it says if these complaints would normally be dealt with by another agency, then they get referred. So importantly in this case, if it's a matter where there's abuse by a staff member or a volunteer within an NDIS service, that will go to the NDIS Quality and Safeguards Commission. Similarly, if it's by staff or volunteers within an aged care setting, including home care, it'll go to the Aged Care Quality and Safety Commissioner. Or if it's by a health professional in a healthcare setting, such as a hospital or other medical service, then it will go to the Healthcare Complaints Commission, effectively meaning that what we deal with is abuse and neglect that exists within the family home and the community settings. And that's an area that doesn't get very much attention. The Royal Commissions that we've had and are having at the moment largely have concentrated on institutional abuse, but ours is about that which happens in the home. And in relation to older people, a couple of really important statistics. About 2/3 to 3/4 of our work is in relation to older people, and the rest is in relation to adults with disability over the age of 18. It won't surprise you that in relation to older people, the vast majority of reports and concerns we have are by other family members. A small percentage, about 10%, are by people themselves that are affected. For people with disability, the major group of reporters are frontline workers being disability support workers, community workers, home care workers, and increasingly healthcare workers in all spaces. In relation to older people, the nature of that abuse is, firstly, it's largely by family members. In fact, nearly 2/3 of all abuse of older people are by their older children, that is adult sons and daughters, or by siblings. And about another 10 or 12% are in fact by spouses and partners. For people a bit younger than in disability, it's slightly different. And the high risk group there are 18 to 25-year-olds, and it's largely by parents and siblings. So this is in fact very much about the abuse within the family unit and about relationships that have gone wrong. In terms of the nature of that abuse, what is it? In relation to older people, it's mainly psychological abuse, and that includes coercive control or coercive conduct. Very significantly, it's about financial abuse. About 30% of the matters we deal with are those, followed by neglect, about 20%, physical abuse, sexual abuse, and others, and exploitation. And just in relation to that, psychological abuse occurs in many of the forms of abuse that we're dealing with. In terms of people with psychosocial disability, about 17% of those matters, which are not simply inquiries, but actually turn into formal matters or statutory reports, about 17% of those are in relation to people that have a psychosocial disability, in relation to older people with disabilities. And for younger people with disabilities, about 10% of the matters we formally deal with are with people with psychosocial disability. And of course, our interaction with NDIS through our official community visitor scheme, which we also administer, takes us into the homes of about 1,800 disability services that are provided under the NDIS in New South Wales. And some of those, of course, are places where people have profound difficulties, including some with very severe psychosocial disabilities. So in trying to engage, the other very important part of all of that, and the most important thing about legislation, it's a will and preference jurisdiction. That is, we are required by law to take into account the wishes of people with disability, no matter what that disability, and older people. And that is something that's in the legislation and we value very much, to the point that we actually record on a quarterly basis and release this data to the public about when we've sought the will and preference of older people and people with disability, but also where we've been able to honour that will and preference. Will and preference is a difficult jurisdiction for the very reason that many older people, whilst they want the abuse to stop, they are much less interested in having their child, their brothers, their sisters being investigated, and some ultimately referred to the New South Wales Police. Nevertheless, we give honour to that expression. And so at the end of the day, we try to work with people to unravel relationships that have gone bad in the family, try to find new support systems in place, try to find advocates that might be able to help them in navigating the systems, but also representing their views. We try to find pro bono legal services where that's required, or in some rare cases, we actually take matters to NCAT where guardianship might be sought. But the whole aim is to try to enhance the well-being and safety of the person with disability, or the older person with disability, and to try to ensure that whatever takes place from the moment that call comes to us, they are in a better position. But it is also true that we do hold people to account. And by law, I'm required to refer matters to the New South Wales Police where I believe there's evidence of a crime taking place. But the notion of listening to older people with disability goes beyond just that. Indeed, before we can carry out an investigation, I'm required to get the consent of the individual. That is, the older person or the person with disability. Will they consent to us investigating? Sometimes we do that in a very gradual way. You know, do you want us to contact service providers? Do you want us to contact family members? And gradually move people to the point where they'll consent to the investigation. But as I've indicated to you in relation to these matters, because it's often family members, an older person may well say to us, as I've said, I want the abuse to stop. I don't want my son stealing the money. I don't want my partner physically abusing me. But then they will say things like, but this is the only person that actually cares for me. And by the way, he's really not a bad boy. And what happens if he actually gets into trouble? Who will care for me? And so often people, notwithstanding their knowledge of what's happening to them, may in fact deny that consent. And unless the risk is very high, we will honour that consent. Otherwise, what's the point in will and preference? Otherwise, what's having legislation in relation to consent? But there is a very interesting phenomenon in the legislation, and that is this. If a person doesn't give consent or refuse it, in other words, they simply don't give an answer, I'm able to overcome that, but only after I've ensured that they've received sufficient support to make that decision. In other words, it's got a supported decision-making element to it. Unsophisticated, uncomplicated, but nevertheless, at the end of the day, we need to ensure not only is the person's voice heard, but where they don't have that voice or don't wish to express that voice, then in fact they receive the supports that are necessary. It's all very well to say we will listen to the voices of people, but if they don't have the supports to make that decision, they're going to be problematic. In relation to people with dementia, it's even more significant. And the reason for that is the assumption by carers, family members, the community, that once you have a diagnosis of dementia, then in fact you're incapable of making decisions. And the truth of the matter is, for a very long period of time, a person diagnosed with dementia has capacities, fading, yes, but hasn't. They may be able to make some decisions without support. They may be able to make some decisions with support. And ultimately, there may be some decisions they can't and maybe require some sort of substitute decision-making to be put in place. Finally, in relation to the systemic issues, I have a whole range of functions that require me to act in relation to systemic issues. One of those, which may surprise you, is a role which is to oversight, that is to report on the implementation of the Australian Disability Strategy by the New South Wales Government. And that, of course, affects all people with all forms of disability, whatever their age, whether or not they're NDIS participants. And that includes people with psychosocial disabilities and even lesser impediments that may arise. So part of us is to make sure that in doing that, we will actually hear from people who have experienced the mainstream service systems, including people with mental health issues, health, transport, accessibility, and over time, a range of issues. Secondly, we engage very heavily in a community engagement strategy, particularly in relation to with groups that have already been established, advocacy groups, peer support groups, and other groups that support people with disability and older people. We have 18 collaboratives which we support, which are like interagencies, and each collaborative that exists has the local district health in it, the local police, the local council, and a whole range of community support groups, including advocacy group and service providers, particularly community-based service providers. And the reason for that is older people connect locally. One of the things I've learned from a lifetime of our public policy is you can, in relation to older people, you have to meet them where they are. You have to engage them in the life that they live, not in the way that bureaucrats and others believe they should. And older people connect locally. And so one of those strategies around collaborations is to engage the local community and the local government in this particular response, and it's very important. And finally, we actually have an expert roundtable, we have a disability roundtable and an older person's roundtable together with a board, which have representatives of and people with lived experience on them. And the reason for that is that if we're going to look at systemic issues, then in fact we need to understand the impacts on the lives of people with that experience, including older people with disability, including people that live with mental health, including those that live with mental health, but also have added burdens and live with, as we said before, psychosocial disabilities. And so again, it's a matter of wanting to do that. Even if the legislation didn't require some of that, we would want to do that, because if we are going to inform systemic issues, then this is going to be critically important. We listen to people. So ours is just one agency, a young agency, but has at its centre the absolute necessity to respect the wishes of people with disability and older people, no matter what their circumstances. And to use that information not only to seek to solve the matters that are formal reports and to create a safer environment for people, but ultimately to change the systems and structures which surround people living with disabilities and or have various vulnerabilities that might exist. The last point is this is all part of a new and emerging public policy area. That is the safeguarding of vulnerable adults. And we have developed a community of practice with other states that are engaged in this. There's a safeguarding unit in South Australia, in ACT. There's active consideration of such in Queensland. And the public advocate in Victoria has recommended something similar to our own agency. So to put this in broader context, this area of emerging concern, this area of public policy around the safeguarding of adults, particularly vulnerable adults, is something that all of us will need to be engaged in if we're going to really help ensure and prevent abuse and respond to that abuse for older people. So Carmel, back to you for other presenters.
Thanks very much, Robert. That was a fascinating presentation, and certainly the work of the Commission is complex and challenging, but I think a lot there for us to dig into when we get to the panel discussion. So thank you very much. So our next speaker is Liz Abbott, and Liz is the Acting Director of the Older Persons Mental Health Policy Unit with the Mental Health Branch at the Ministry of Health. And Liz has got extensive experience working as a clinical nurse consultant, older persons mental health services clinical coordinator, and a partnerships coordinator. And in her current role, Liz is providing policy advice, liaising with the Commonwealth, and managing the Mental Health Residential Aged Care Partnerships Initiative as part of the Pathways to Community Living program. So Liz, over to you. And I can see that Liz has put her presentation up. So I'll disappear and come back at the end of Liz's presentation. Thanks.
Thanks, Carmel. And I just wanted to also thank you for putting me to follow Robert in this presentation. It's a hard act to follow, but anyway, I'll give it my best shot. So yes, thank you for the invitation to present at today's webinar. Advocates and allies within New South Wales Older People's Mental Health Service. I'm going to start by discussing some of the issues for older people. So firstly, I would also like to start by acknowledging the traditional owners of the land on which we're all dialing in from today. For me, it's the Camaragal people, and pay my respects to elders past and present, and to any Aboriginal people joining this webinar. And I'd also like to acknowledge all people who have a personal experience of mental health issues, as well as their carers and loved ones. And the voice of people with lived experience is essential in the development of our work and is why we're here today. So just to, by way of background, just to orientate you to the work we do. So the Older People's Mental Health Policy Unit is based in the Mental Health Branch at the New South Wales Ministry of Health. And whilst we're a policy unit, we do have a lot to do with the development of clinical services in the local health districts. And I just thought I'd provide a brief description of how mental illness presents in older people and some of the specific issues this might bring for older people. So you're probably all aware of this, but some older people will develop a mental illness as they age, while others grow older with a mental illness that has developed earlier in their lives. And I think one of the main things about our services is we don't automatically see people once they turn 65. We also, people will often remain with the adult mental health service, and I think it's largely about choice and control for those people as well, to which services they might end up using. Depression, anxiety disorders, schizophrenia, and other psychotic illnesses are key mental health issues for older people, along with alcohol and substance misuse disorders. So we work quite closely with alcohol and other drug services as well. Aging brings increased risk of dementia. Behavioural and psychological symptoms of dementia are common, and we do see a lot of people with those sort of issues as well. Suicide's a significant risk for older people, particularly older men, and depression is an important risk factor for suicide in later life, and Bryan Hoolahan is going to speak to that. And as the New South Wales population ages, the number of older people with mental illness is projected to increase significantly to approximately 260,000 people in 2026. And there are differences in presentations, obviously, in older people. Often it's made more difficult with physical illness and other physical health issues, the stigma and under recognition, particularly in residential aged care, but mental health treatments are effective in this population. So I'm just going to give a snapshot of where the older people's mental health clinical services are within New South Wales. So we've got inpatient units in most of the LHDs. We've got some with subacute units. All local health districts have a community mental health team for older people. And then we also have the mental health residential aged care partnership services, which expand across metropolitan and some regional areas as well. And for a lot of people, as I've already said, adult mental health services remain important for older people, and particularly around emergency responses, and choice is an important factor for people as well. So how do we make sure that we include the voice of consumers in our policy work? I think it's an area that has been strengthened over in the last 10 years in older people's mental health. So these are just a snapshot of some of the service planning and models of care that we have developed over the last 10 to 15 years. Consumers and carers are consulted throughout all these processes to develop these key policies. And as you can see, there's a number of projects and policies here, and they all have older people, consumers and carers involved in consultations to develop these models and services. And as just mentioned, consumer and carer consultations and consultation with our partner organisations is a key component in development of our service models and programs. And of particular note, the consultations for key documents, including the service plan and model of care, made it clear for older people that recovery remains just as important for older people as for younger people. And recovery in older people may require assistance from individuals with specialised knowledge, but fundamentally it requires the maintenance of hope by the person, their family and carers. And consumers and carers made it clear that this is required from the point of contact with the mental health service and throughout their continued involvement. I'm going to move on now to this diagram, and you'll find this in our service plan. I can provide links for any of the plans that we have, but this diagram shows how recovery and recovery-oriented practice is central to planning of older people's mental health services. The recovery journey for older person is a key focus, recognising that there are many elements and domains that contribute to recovery and a meaningful life. And that includes personal relationships, occupation, accommodation, spirituality, leisure, social connectedness, personal development and health, and that specialist older people's mental health services are only part of the network of services and supports that will assist a person's recovery journey. So this is one of the projects that I was referring to, and it's hard to sort of just draw out some of the components of the work we do because it's so broad, but in 10 to 15 minutes I just thought I'd pick out some of the major projects that we've been working on. So this is the Older People's Mental Health Recovery Project. It was a project, it's a statewide project, and it was aimed to provide recovery-oriented practice in New South Wales older people's mental health community in inpatient teams, supporting services to translate policy into practice improvement. And it was adopting a start where you can approach. So 13 projects were developed across 11 LHDs, and they all progressed to completion. These projects were co-designed, and consumer involvement was central to the development of the project at the state level, as well as most of the LHD projects. And this is just a couple of examples of projects that we had. So uniqueness of the individual, real choices. So that was looking at reorienting staff to recovery-oriented practice through education and introducing collaborative care planning practice. Attitudes and rights, measuring the recovery attitudes of one of the LHDs. dignity and respect. So that was around older people's mental health peer workforce, partnerships and communication, and evaluating recovery. And the project methodology was seen as highly successful and has resulted in ongoing service changes, with many of these having started ongoing shifts in how care is delivered. It also resulted in the first peer workforce, first older people's mental health peer workforce, and continued translation of evidence into practice. And the co-design and consumer involvement has really become standard business for practice improvement initiatives across the older people's mental health workforce. The methodology also was the genesis for the physical health project and laid a strong foundation for future translation research and practice improvement in older people's mental health. And I'll move on to the older people's mental health physical health project. So this was a state-level project sought to support stakeholders in developing and implementing practice improvements to enhance the physical health outcomes for older people with mental illness. The project has successfully progressed 8 translational research projects across 11 LHDs and supporting teams to translate policy into practice. Most projects adopted a co-design methodology with consumers and carers, or had peer workers and consumer consultants directly involved in implementation. This was achieved primarily with existing resources without additional funding from New South Wales Health. The key benefits were these statewide projects aimed at improving practice, changing culture, evaluating outcomes, and ensuring recovery-oriented, trauma-informed services are provided to older people. It's just to give you an idea of where these projects were conducted across the state. So we had, a lot obviously metropolitan Sydney, but also we cover some of the more regional areas as well. Most LHDs had a nominated project champion and a supporting manager to provide the local management support for their project. And there's been a lot of interest statewide, particularly around physical health care and mental health from this project as well. So these are some of the projects. So there was one with NEMI, it was a physical health prompt, one with Flourish, Live Well, Fit for Life. So a lot of it was around collaborating with CMOs, developing either tools to assess people's physical health needs, developing exercise programs that were suitable for older people's mental health needs. And as I said, these were all co-designed, so obviously developed by LHD clinicians with consumers and carers and peer workers. So there's a whole range of them, optimise health, and some of these are being published at the moment as well, which is pretty exciting. And again, I can provide all this information at a later date. Now I'm going to move on to another area. We're heavily involved in the pathways to community living. So I'm not sure if anyone's aware of this, but it's a major system reform program with a focus on people experiencing severe and persistent mental illness and exceptionally complex needs who have experienced long stays in inpatient services, or who are at risk of long stays or recurrent hospitalisations. So the program was established in 2015, and New South Wales had over 380 people who were in mental health inpatient units who were long stay. So some of them had been in the hospital system for 10 years, some 15, some 20 years. So, for some older people as well, half their lives had been spent in an inpatient unit. So through PCLI, New South Wales has led a comprehensive and person-centred approach to working with these individuals and developed strong partnerships with community-based services. This has enabled the majority of these individuals to successfully transition to the community and created pathways to community-based care that will also help prevent long stays and provide improved care and support in the future. I'm going to focus on stage 1 consumers with significant issues of ageing for this presentation, many of whom are eligible for support within the Australian Government aged care programs, in particular residential aged care. These people generally require ongoing support from New South Wales older people mental health services or an older person's mental health clinician. So just to provide a bit more context, this group of people with complex mental health needs and ageing issues, there were a significant number of people, as I said, with a stay over 5 years, with several people spending more than 20 years in hospital. So the target group for what we call stage 1, so they're people either over 65 or people under 65, but with ageing needs. We've managed to provide comprehensive assessments and work with these individuals to move them into much more suitable accommodation. Well, not to move, it's their choice, but yes, to transition them into accommodation that's much more supportive and appropriate for their needs. So the PCLI approach is focused on the person's individual journey. We use a number of resources, one of which is called Getting to Know You. So that refers to the individual transition process promoted by PCLI. There are tailored assessments for individual consumers, and the tailored assessments provide detailed information on what that person's strengths are. We try and use a very strengths-based approach for PCLI. And the specific assessment tools are intended to be integral to the transition process, and we use them selected by a group of senior practitioners to complement the national mandated mental health outcome assessment tool we use in New South Wales. Baseline assessments provide insight into the health status of consumers in hospital, and follow-up assessments provide an opportunity to monitor their health outcomes after assessment, and also helps with the evaluation process. So just to touch on some of the successful transitions we've had into the community. So we do have 3 aged care partnership models. This is within the stage 1 services for older people or people who are younger with aged care needs. We've got generalist residential aged care facilities. We have the specialist mental health aged care transition units, and we have specialist residential aged care facilities. And all these services, the 2 specialists, so the MACP and the specialist facility, are provided with top-up funding from New South Wales Health, and are provided with older people's mental health clinicians or PCLI or people's mental health clinicians to support transitions for these people into the community. So as at 31st of December 2019, 31 stage 1 long stay consumers have transitioned to the community. Over 50% of these people were transitioned, 113 people have been transitioned to the community. So over 50% of those have gone to a generalist residential aged care facility, and 34 to a MACP, and 22 to a specialist facility. I'll talk a little bit about their experiences and outcomes. So for the health outcomes for people who've been transitioned into these facilities, the health outcomes were generally positive. Psychological distress following transition improved, and there were significant improved life skills, particularly self-care and social interaction. Physical health care, obviously, because of the age of some of these people, has continued to deteriorate. Hospital readmissions were uncommon, with 16.9% of people transitioned to the community with had a short admission to an acute older people's mental health inpatient unit, and that was generally for stabilisation of medication. And the experience of people interviewed in the evaluation highlighted improved engagement, choice and control in their daily lives following transition to the community. And they also identified better engagement in community activities and a more meaningful life in a less restrictive environment. When consumers and carers talked about the new accommodation and supports in the community, they identified features which made these places feel like home. Private space where a person can have their own things, feeling safe and socially connected, being treated with dignity and respected by staff, having opportunities to live more independently, and freedom to make choices and decisions about their lives. Consumers told the evaluation team that their mental health and wellbeing had improved since transition. Carers highlighted an improvement in the overall health and wellbeing of the person prior to transition. Many of the carers were concerned about the people leaving hospital, but report their fears being alleviated once they'd settled in, and were very positive about the environment. For improve relationships with the person, and they also reported greater opportunities for family and community engagement. Stage 1 consumers who require aged care have 3 options, as I mentioned. So we've got the generalist, the MACV, and the specialist facility, and most of the evaluations were very similar for those 3 types of models. That, you know, people's quality of life did actually improve once they moved out of hospital, which is surprising. So just again to sort of highlight some of those improved experiences for people who'd moved out through PCLI, positive health outcomes, including reduced psychological distress, the low need for unplanned acute care admissions, improved engagement, choice and control, and carers were seeing that they also had a much more meaningful life. We also looked at the experiences for service providers and clinicians, and there was a really quite a dramatic cultural change, and particularly towards a recovery and coordinated complex care for these people, and really understanding what complex care needs are and how we best meet some of those needs, and effective engagement across the hospital community and aged care settings. So we have a network of residential aged care, PCLI and older people's mental health services that meet quarterly, and it's a really invigorated meeting, and we benchmark some of the facilities, look at some of the trends, and discuss and share information with those groups. The other thing was improved efficacy and effectiveness of the system. So some of the successful transitions and increased bed capacity. So there's always issues around bed block in acute services. So we found that some of that was reduced. There was a reduction in the total length of stay for people across all New South Wales acute units. And there was economic analysis as well that I won't go into, but it demonstrated that it was very cost effective for them, and the capacity to reshape mental health non-acute patient models. Where they're no longer homes for people, we realise that it's not somebody's home, and the quality of life for those people will improve once those acute facilities. Then the next slide is just the evaluation that we've done that I can provide a link for. So I'll go back to you, Carmel, and stop sharing my screen.
Great. Thanks. Thanks very much, Liz. That was a great presentation, and really interesting to hear the outcomes in more detail of the Pathways to Community Living initiative, because it's been such a big and important initiative, and to see it getting those sort of results, you and your team must be very pleased. But more importantly, for the people who are a part of that, it's making a real difference to their lives. So I know people are quite interested in the various different links that you said you'd share. So that would be great. And I will just let people know that all of the presenters have agreed to share their slides. So we'll be circulating those to people after the meeting as well. Thanks, Liz. So we're now going to move to our next speaker, who is Bryan Hoolahan. And Bryan is also at the Older Persons Mental Health Policy Unit. Bryan is the Senior Policy Officer there. He's a registered psychologist and executive manager with over 20 years of experience within the health, not-for-profit, government and tertiary education sectors. So Bryan, over to you.
Thank you, Carmel, and good afternoon, everyone. I'll just start to share my screen. I'm trusting everyone can see that. Just before I start, I would also like to acknowledge the traditional owners of the land on which we're meeting. I'm coming from Wiradjuri country. I'll pay my respects to their elders past and present, and extend that respect to any Aboriginal people at the meeting today, and also just acknowledge the importance of people with a lived experience to the work that we do, and how important their voices are in shaping our services. So I'm aware today that I have a fairly short time frame to cover some fairly complex areas. So I am focusing today on some of the work that I've been involved in within the unit, particularly around older people's suicide prevention. Now, I know you've had a previous presentation at this forum by the Towards Zero Suicide team, so I'm not going to go back in time to that. But in particular, we're working from our unit's perspective on a few things that we feel are fairly important to suicide prevention for older people in that context. So I've selected a couple of the things we're doing, which in particular have involved the consultation with people with the lived experience of suicide, in particular the older people suicide prevention lived experience consultation that we did, and an aftercare for older persons report. So I'll try and cover the key findings of those activities. And then I'd like to just switch gear to talk about some of the work we're doing in older people's peer workforce development, which is really a work in progress, but a very critical area for our services to develop. And I thought you may be interested in some of the things we're doing there. So to begin, I think it's important to start by acknowledging that the strengths of older people and the resilience of older people. So as we age, the evidence does suggest that we do build resilience, particularly towards life challenges and change in our lives. And as we get older, we don't necessarily become less resilient, but certainly there are some vulnerabilities in aging that we need to be aware of. And one of those particular vulnerabilities is particularly around men 85 years and older who have the highest suicide rate in Australia, which is 3 times higher than the current population rate for Australia in general. Also, evidence from internationally suggests that older consumers can account for between 4 to 15% of all deliberate self-harm admissions, and that older people who experience deliberate self-harm have been reported to have a higher level of suicidal intent and a death to attempt rate between 4 to 1, which is extremely high. If you look at some of the older age groups, it's been reported to something like 200 to 1. So you have a very small number of people, but a very high risk level. In New South Wales, as a part of the Towards Suicide initiatives, we also have a suicide data monitoring system, which publishes data on the New South Wales Health website every month. Below is the data from the most recent report, which is in September. And I just wanted to draw your attention, obviously, to the older age groups. You'll see the 85 plus at the bottom there, but in particular, highlighting the, the rates of apparently increasing suicide between 75 to 84 year age groups. So we don't have obviously the full data for this year, 2022, but that will come out obviously in the new year. But that just showcases, I think, that the older age groups are quite vulnerable in terms of suicide and self-harm, and that is an area in our older people's policy unit that we're very keen to work on. So let's just go into the next slide. Oh, there we go. So just in terms of the consultation we did with older people with a lived experience of suicide. So it was in early 2021, the ministry engaged NGO Roses in the Ocean to undertake a co-designed consultation process involving older people with a lived experience of suicide, as well as some health professionals across New South Wales LHDs. Now, the consultation was designed to try and understand how suicide prevention services can better meet the needs of older people. The feedback from this consultation was at that time used to inform the development of the safe haven projects which are happening around the state, as well as the suicide prevention outreach teams, and as well giving us a lot of information about older people's suicide prevention needs for potential other suicide prevention activities. So within that consultation, there was a number of questions that were asked. I've just picked out a couple of those which I think illustrate some of the feelings and thoughts of older people who are experiencing suicidal distress. So the first one showcasing here is, what feelings have you experienced when thinking of reaching out for support? Perhaps not surprisingly, there's a lot of comment around the stigma, I suppose, of suicide for older people, feeling disconnected, the guilt associated with that, mistrust of services in particular, feeling exposed, isolated, etc. And I guess that's not specific to just older people. I think when you talk to a lot of consumers reaching out for support when they feel suicidal distress, these are some of the feelings that they relate, but I think particularly illustrates the feelings of older people at that time. We also asked, why did you not or would you not seek help through emergency departments, which in particular was an interest for our services, which is a common access point for a lot of consumers seeking help at times of distress. Some of the key themes that were reflected were a perception that they wouldn't be listened to, fear of having their freedom removed, fear of physical restraint, negative past experiences with clinical mental health supports, a perception they couldn't do anything to help, a fear of losing control, and societal pressure. So a number of those key themes reflect, I think, that element of losing control and not having agency over what will happen to you within a health service if you present with a suicidal concern. Now, we didn't particularly dig into the whys during the consultation process. However, a number of these consumers were over the age of 70, 70 through to 80, and perhaps some of their feelings towards services were shaped by early perceptions of services but in the 1970s and 80s. So when the system was obviously heavily institutionalized and perhaps not as enlightened around restraint and seclusion, and certainly didn't have the involvement of peer workers and consumers to advocate for health services. So I think there is a perception there that we need to definitely work on within the services around New South Wales to try and dispel the fears around seeking help and some of the things that may happen if you do reach out. Sorry, there's a lot of text on this page, but this is the findings of the consultation as they were found in the report. And they were that older people need suicide prevention services that are designed to meet their unique needs, and that they must provide more than just crisis care, but also generalised support for maintaining a positive mental health and well-being. And that, of course, older people should be involved in the co-design of those services. Suicide prevention services should be non-clinical in nature and encourage and champion older people to maintain their autonomy and social connectedness. The carers of older people experiencing emotional distress or suicidal crisis need services also that are flexible and accommodating and provide a social outlet for them to develop natural support networks. It's important that we normalise mental health and suicidal crisis and reaching out for help, and it will be critical in overcoming this stigma that we just mentioned there, and some of the misconceptions and general mindsets currently acting as a barrier to entry for older people. Services offered within residential aged care facilities to support a resident's mental health and wellbeing are also lacking, and in need of some tailored place-based or mobile services to overcome some of the access difficulties and challenges faced by these individuals. I'd also recommend to you that during the process of this consultation, Roses in the Ocean actually did some video interviews with older people who have experienced suicidal crisis. They've got 5 of those on their website, which are very worth you spending your time to have a listen to, because they're extremely enlightening about the voices of people who have actually been through a suicidal crisis and how they felt and what would have helped them at that time. So I'll just move on now to our work around aftercare. Now, aftercare, if you're not aware, is a support service for people who have recently attempted suicide. It's become increasingly a critical element in terms of suicide prevention. And when someone reaches out post a suicide attempt, the level of support they receive through an aftercare service can be up to 3 months support, and they provide encouragement, coaching, development of personalised safety plans, and refer people to connect to either clinical or community support services. And they also support people to attend these appointments, mainly through a virtual service in many of the funded services. But they also provide access to formal and informal supports to promote recovery. Now, New South Wales has currently 9 funded services based on the Wayback model, which was developed by Beyond Blue. When we looked at the aftercare models from the Older People's Policy Unit viewpoint, we found that only about 3% of the participants are 65 or over. So we really started to ask ourselves, what is the barrier here for older people, and why are we not seeing older people access some of these services? And to understand that, we really felt we needed to do a bit more of a comprehensive look at what the literature says about aftercare and specifically for older people, and some of the evidence around that. So we actually commissioned the University of New South Wales, and Dr. Anne Wan and Professor Carmel Pisa specifically were involved in this work to look into that evidence base, and also to conduct consultations again with older people with a lived experience to really understand how aftercare services could work for them in the future. So when Carmel and Anne conducted their literature review, which was extremely extensive, they found that the current evidence base really indicates that a discrete aftercare service, such as it's currently conceptualised in the community, is not really fit for purpose for older people for a number of reasons. They found that older adults may face ageism and ageist attitudes, including the belief that older people's lives are less valuable than younger people. Suicide attempts are not taken seriously, or even perceived as understandable. The connections between suicide, human rights violation, and ageism has previously been considered in a number of research articles, and in particular, the risk factors associated with suicide in older people may be exacerbated by those violations and represent downstream effects of ageism. So, in summary, that indicates that not just our services, but perhaps the broader community definitely have ageist attitudes that perhaps provide barriers to older people seeking services, and perhaps even exacerbate their suicidal distress. So in terms of a model of care that would be useful for older people, the core principles that were outlined during this report were that we need to raise awareness, which is really about understanding that suicide is a very real risk for older people, in particular older men, as I previously mentioned, and that these services must be person-centered and trauma-informed, and they have to be paced and meaningful to meet an older person's specific needs. And the connection and collaboration piece, which makes all our services function more effectively through creating better accessibility, imparting hope, creating empowered consumers, and working in partnership with all services, both within health and outside in the community. So in particular, when they looked at what elements would be useful within a health-based service, Anne and Carmel found that early identification is key in terms of supporting older people at risk of suicide, that a low threshold and early referral to older people's specialist services is very important, that a rapid and assertive follow-up, ideally face-to-face within 24 to 48 hours, is also critical. And this should also be linked with higher intensity of scheduled care contact in the initial weeks after presentation. So fairly regular and intense contact post a suicide attempt. We need to increase the timely and appropriate intervention through our specialist older people mental health services, which Liz highlighted in her presentation. We need to include the older people and their families and carers in the planning and decision-making around those services. And a continuity of care and communication across services is absolutely critical in terms of maintaining engagement with those services. Particularly with older people, we see they are transferred between a number of services. So that may be not just mental health services, but often when an older person presents to a health service, they have other health issues that require intervention. And that can mean that they're involved with a number of services at the one time. So enhanced transfer of care and a warm handover is absolutely critical in terms of information flow and being able to support a better care experience for older people. And finally, a specific education and training piece is required around suicide and self-harm in older people, which again will help to build that awareness piece around the vulnerability of older people in suicide, but also start to improve people's confidence with working with older people who might be in suicidal distress. Sorry, now I need to change gears to start to talk about our older people's peer workforce initiative. So as I mentioned, this is really a work in progress. And while the concept obviously of a peer workforce is quite well established, and the benefits of having a peer workforce is quite well established. However, in older people's services around the state, they're not as common to see a older person's peer workforce within our services. During COVID, there was a number of supplementary funded initiatives where some services actually took the initiative to try and engage older people with a lived experience to work within the services, which really gave us an insight into some of the benefits, but also some of the challenges of establishing such a workforce. So in February 2021, we actually held a forum, which was quite early days in terms of trying to understand what we needed to do in terms of an older people's peer workforce. The key issues at that forum that came from the floor included that more research was really needed about what makes an effective older people's peer worker, that most older people's peer workforce that were engaged were younger than 65 years of age, that there was crossover issues between peer workforce, older people's peer workforce. However, it was critical that older people's peer workers had some sort of understanding of aging and the aging process to be effective in that work. Services also needed to consider some flexibility in terms of employment conditions and the mandatory training when trying to establish an older person's peer workforce. We found that there is a component of that workforce that don't wish to be paid or have some concerns that payment may affect their pension. I guess in the older age groups who are looking to get involved in this work are not necessarily looking at it as a career or a job in those terms, but perhaps just wanting to give back. They may be of retirement age and have extreme experience generated over the years of their life, but not wanting to be formally engaged. So that does bring about some challenges, I think, in terms of supporting that workforce within our services. There was also comments around that the role at that time in February 2021 of a peer worker was not well understood in health services in particular. I think that may have changed somewhat in the last 12 to 18 months that we've been working on this issue. Transferable experience to clinicians was definitely one of the benefits that the services reported. So it was the ability for the peer worker to be more recovery focused and actually provide valuable education to the clinicians working within the service as well. And finally, the supervision of those peer workers was essential, and it was suggested that pairing an older person's peer worker with a senior peer worker as a mentor was seen as very beneficial if that was possible within the service. So what we're trying to do this year, and again, we haven't held this forum yet, it's coming up this week actually, so I would be happy to come back at some point if Carmel would like that, to report more on what we found out around our second forum about older people's peer workforce. But really what we're looking to do with this forum this week is to progress the discussion around the development of a peer workforce that is appropriate for older people. So this forum will include older people's mental health services, specifically the managers, clinicians, peer workers and carers involved in those services. And some of the questions we're trying to answer within this forum will be, what does a peer worker look like for an older person? How can we define that role? There's certainly been a lot of work around defining and scoping peer workforce, but what does that actually mean for an older person within the service? What are some of the benefits of older people having access to a peer worker? And what are the key things that need to be in place for a successful older person's peer workforce? What are some of the challenges and barriers of establishing an older person's peer workforce? And what support information do the local health districts need for recruiting and retaining an older person's peer workforce? So very excited about that forum, and hopefully that will bring about a new lot of information that we can take forward within the services to shape an older person's peer workforce.
Great, thanks, Bryan.
Yep.
That's a really good transition, I think, into our panel discussion, and you've put some resources up there, and we will be circulating, as I said, the slides to the participants, so they'll be able to access all of that information. But of course, our fourth presenter on the screen today who will be joining the panel discussion is Bharat Nepal, and Bharat is a senior peer worker with the Pathways to Community Living older people's mental health team based at Cumberland Hospital. So I think, Bryan, that information that you're providing us about the senior peer workers, for older people, Bharat will be able to very much speak to that when we get into the panel discussion. So thanks, Bryan, for the presentation. I would ask our presenters to all join us now as we move into the panel discussion. They've all been great presentations and a lot there to discuss. Probably not as much time for the panel discussion as we would like. But Bharat, I might go to you first, because certainly what we were just hearing from Bryan, you know, that sort of less knowledge and awareness about what a peer worker brings within older people's mental health services. It'd be great to hear your experience of just about what your role is. What are some of the challenges? What are the rewards? What do you do as an older person's mental health peer worker?
Thank you, Carmel, and thank you everyone for wonderful presentation. It's a comprehensive question, I guess. It might be hard to cover broader aspects of it. I think one of the challenge often is providing support to older persons, and whether the person providing support is old enough, or does the person have the life skills, is often the question I hear as well. What I've learned working with the older people is that it's not so much about the person's age, it's the wisdom, the support, the understanding and willingness to share the experiences, knowledge, and validating the experience, skills, and expertise the older person has, and providing support to enhance that. And that works much more powerfully and enables the person to take next step and navigate the challenges, whatever the person is experiencing at the moment. So what I have been doing, even doing before the peer work role, I used to work with the older peoples in population health. So I have been working with the older people for quite some time, over 15 years. And I have not got much comment about my age, more about how I work with older people. So that, I think that relates much more. Now, challenges, I think Bryan did highlight that peer work. I've been in this role for 4 years and I still get questions. So what do you do? By the way, what is peer work? So I think we do need to do quite some more work to educate the mental health workforce, what is peer work and how to work with the peer workers as well. So that bit is there. I think it's a continuous work. In terms of the benefits, the rewards, being able to support the person, and when the person transitions to the community, lives meaningful life, and cheekily telling, thank you, but I don't want to see you guys anymore. I'm doing well in the community and I'm being supported. It's, thank you for whatever you guys have done. But, we want to live our lives in the community differently. And that is the reward. Sounds a bit weird, but it is. Yeah.
No, I think we can all relate to that. I guess that satisfaction about being able to support someone to live their life as they wish, as you say, Bharat. I think that's very, very rewarding. Do you find, or have you found that over the last few years that you've been in the role, that clinical teams are now coming to understand and value more the role of peer workers?
There has been improvement. Probably I'm a little bit impatient. I wanted those improvements a little bit faster, a bit broader, but definitely that I've noticed the changes, even with the senior clinicians, the language, the way the meetings are conducted, how it is expressed, much more improvement, but I think that needs to go further. And it's not just one way. I guess peer workers do need to be ready to provide that education. And for the senior management from the senior level, leadership level, if there is no embracement and highlighting the importance of it, it sort of dies down when it comes down to the front line. So I think that bit is a little bit re-energizing is required, is what I feel. But of course, other colleagues who have been working in different parts of New South Wales may have different experience. And one of the challenges, I think, being the longer institutions or establishments like Cumberland Hospital do have long history, and then it might be a little bit harder to bring the changes compared to the newer facilities and establishments. This is my guess, so yeah.
No doubt many of these issues will be for discussion at the forum that Bryan mentioned. So I think there'll be a lot of interest in that. Thanks, Bharat. Now, I know we are at the point at which the webinar is due to finish. I might just see if our participants could stay for another 5 minutes, because there are a few questions in the chat function. We're not going to get to them all, but we will try and respond to them. But Robert, there's one about concern with regards to the Mental Health Act, and that in different states in Australia, the Mental Health Act sanctions the abuse of human, aged and disability rights, and wanting to know if your team can advocate for positive change in the Mental Health Acts. Now, I feel maybe, as you explained at the beginning, the Commission only gets involved in areas where there are not other organisations or legislation covering the field, but I don't know if you can respond to that at all.
Broadly, because of the systemic role that we can play, we can try to influence various pieces of legislation around people with disability and older people more generally, and we would do that. There is a constant contest in this space. As you would know, for example, just one example is about restrictive practices, authorisations for people with disability and now for older people within residential aged care. And so many people would say, for example, that's an abuse of a right and shouldn't be authorised at all. On the other hand, many people say actually that's unworkable, and in fact these practices need to be able to be authorised. So it's a space of enormous contestability. Where we can bring evidence to bear is what this means in practice. So look, the long and the short of it is, if the work we do, and it's about all people with disability at all ages over the age of 18, no matter what, we can inform those issues. And if the Mental Health Act or any other particular act is seen to be prejudicial to the rights of people with disabilities, including those with psychosocial disability, we can in fact try to influence that. But everyone on this screen knows that these are contested areas. I think we have made significant progress. I know many people wouldn't. And I do think even with the NDIS, we've learnt a great deal, and there's a lot that needs to now be fixed in that space. What is clear is that rights are starting to be at the centre of a lot of the legislation and a lot of the service provision. And it's a long time coming, but we are starting to see that in reality, not just wishful thinking.
That's right. And of course, thank you, Robert. Thank you. I think the person who asked that question will welcome that response. And of course, with the NDIS, there is the review that the federal government has recently announced, which will look at a whole raft of issues, including some of the things that I know people are flagging in the Q&A and chat function. Liz, there's a question here, and we might have to make this the last question, but it's asking, when will the people who are still in long-stay hospitalisation be transitioned to SRACFs? Are facilities being built? I think you touched on that in your presentation, but I don't know if you've got more you can share.
Yeah, so we do have a network of facilities, and we have 80 beds at the moment. There's about 35 of those are not currently operational, but we are expecting an additional 22 beds to come online next about September, October, and an additional 10 in another facility sort of midterm. But I think if those people are sitting in acute units, generally PCLI are aware of them. We do provide input in, like we get an idea of the numbers of people who are still sitting in long stay beds and the length of stay. And we do work with the PCLI clinicians and teams to individually look at that person and work out what their needs are and which facility they might best be suited to. So there is work ongoing, but in relation to those additional resources, definitely next year.
Thanks, Liz. Well, look, we will leave it there. There are a lot of questions in the chat function, a lot of comments. I think it just shows that there's enormous interest in this topic, and also that the presentations from all of our panelists and the comments were of great value to the audience. So this will be no doubt a topic that we will revisit again in the new year. We'll be continuing our Advocates and Allies series in the new year. But I would like to thank all of our presenters, Bharat, Robert, Bryan and Liz. There's lots of comments about great presentations. Thanks, everyone. Fabulous. So, yeah, really appreciate that. Well done. I do want to just let people know that the webinar will be on our website in a few days' time, so you'll be able to access the recording. And you'll also be sent, this is for the participants, you'll be sent an evaluation after this, and we would very much appreciate you completing that evaluation. I know everyone gets asked to complete evaluations these days, but it does help us demonstrate to our funding body that the work we do is of value and is recognised by participants. So please, if you can fill in the evaluation, I would appreciate that. Again, thank you to all our panellists, much appreciated. Have a great afternoon, everyone. Goodbye.